Hello, this is Sean Dobbin at the University of Rochester Medical Center, and today we will be speaking with Dr. Patricia Stewart and Brienne Schmidt. Dr. Stewart is an assistant professor in pediatrics. She's bionutrition manager of the Clinical Research Center, and she's also a registered dietitian. Brienne is also a registered dietitian, and she is the clinical nutrition specialist in the Division of Neurodevelopmental and Behavioral Pediatrics. And we're going to be talking to them about their recent study titled Dietary Supplementation in Children with Autism Spectrum Disorders, Common, Insufficient, and Excessive. It's an observational cross-sectional study that is published in the Journal of the Academy of Nutrition and Dietetics. So, Dr. Stewart, dietary supplements in children with autism, how did you become interested in that topic?
Thank you, Sean. As background, I'd like to start by reviewing the data on the prevalence of autism in the United States. In 2010, based on the CDC's Autism and Developmental Disabilities Monitoring Network, about 1 in 68 children 8 years of age were identified with ASD. That was roughly 30% higher than the estimate in 2008, 60% higher than the estimate in 2006, and 120% higher than the estimate for the years 2000 and 2002. We don't know what is causing this increase in prevalence. Some of it may be due to the way children are identified, diagnosed, and surveyed in their local communities, but exactly how much is related to detection versus other etiologies is unknown. We did this study because children with autism spectrum disorder often are very selective eaters. This may be because of their repetitive and restrictive interest or because they have true sensory differences. In any case, children with autism eat fewer foods than other children, which causes their parents to become concerned about their nutrition. This is one reason why so many children with ASD are given nutritional supplements, such as vitamins and other nutritional products. The other reason why families give nutritional supplements to children with autism is because they believe there are metabolic abnormalities or deficiencies that, if corrected, would improve their child's behavior or decrease the symptoms of autism. For example, a popular but as of yet unproven nutritional therapy is the use of high doses of vitamin B12. Because children with ASD are given nutritional supplements more frequently and for different reasons than children in the general pediatric population, we wanted to know if the supplements they were given cover the gaps in nutrient intake or whether the supplements might lead to excessive intake beyond the tolerable upper limit, which would increase the risk of side effects.
Okay, great. I'll direct the next one to Brienne. How did you go about investigating this?
Well, this study was funded through the Autism Speaks Autism Treatment Network, which is a collaborative of network of hospitals, physicians, researchers, and families across the United States and Canada. At the 5 ASATN sites that we recruited from, we recruited over 300 kids with autism aged 2 to 11 years old who were characterized using the ASATN protocol, and we examined their food intake from food and dietary supplements using 3-day food records. We also collected anthropometric data, information on bowel habits, mealtime behavior, and some nutritional lab indices. Parents completed a 3-day food record that contained all foods, beverages, and supplements ingested by the child over 3 consecutive days, which included 1 weekend day. A registered dietitian or trained research assistant at each site used a standardized method to instruct parents how to record the food records, emphasizing the importance of measurement, added ingredients, and brands. Supplements were recorded on each day of the 3-day food record as well, and we took multiple pictures of each supplement bottle so that we could ensure accuracy when we were entering the supplements into the program. Dietitians at each site reviewed the records and contacted the parents for any missing details. The 3-day food records were then analyzed using nutrition data systems for research.
Okay. So I know your study required caregivers to prepare, contemporaneous dietary food records for the children, which were then analyzed and confirmed by a dietitian. Why is this level of checking and double-checking so important in dietary studies?
In order to ensure the analysis of the dietary intake is as accurate as possible, NDSR actually prompts for a number of details, including brand and cooking methods. As previously mentioned, we educated the families on how to properly fill out the 3-day food record, and we also closely reviewed the food records after the food record was received, and we got in touch with the parents of the participants to gather any missing data. So if they forgot, ketchup on one day, and they always had chicken nuggets with ketchup. So we did this so that we could gather any missing data or get any necessary clarifications. It was not only important to clarify brands, condiments, cooking methods, etc. for the foods and beverages, but it was also important to clarify the supplementation component as well. And as I mentioned before, we actually took pictures of each supplement so that when they were entered into NDSR, and we essentially went through and entered each supplement or nutrient by nutrient, so that they'd be representative of the supplement the child actually took. This is especially important as dietary supplement formulations change quite regularly, and therefore the information that's often found on a website is not as accurate as having the actual picture of the product the child took. As you mentioned, we double and really triple checked both the food and the supplement data that was collected and entered in a way that we were hoping to produce the most accurate analysis of the dietary intake of children with ASD.
Okay, great. We'll go back to Dr. Stewart now. Tell me about the results. What did you find?
So here's what we found. We found the nutritional supplements typically given to children with ASD did not cover the gaps in nutrient intake. On the other hand, many of the nutrients provided in the supplements resulted in excessive intake beyond the tolerable upper limit, which is the highest recommended level of intake above which the risk of side effects increases. This was especially true for younger children who have lower absolute recommended levels of intake. Multivitamins, the most common supplement provided to these children, tended to provide more of what they were already consuming in adequate amounts from the diet and not enough of the nutrients consumed in inadequate amounts. We also found the nutritional intake of kids on the gluten-free, casein-free diet, which is an example of a diet trialed by some families for therapy, was similar to the nutrition intake of children who were not on the diet. However, those on the diet were more likely to be given supplements. Children on the diet were also more likely to achieve adequate intake levels for vitamin D when supplemented. However, despite supplementation, many children, whether on or not on the diet, still did not achieve the recommended levels of intake for calcium. In addition, some of the nutrients that were deficient in the diet, such as potassium and choline, are rarely found in supplements, indicating supplements are not a substitute for real food.
I see. So, based on children's needs for micronutrients, is it surprising that many of these needs are met from normal food consumption, both for ASD children and children in general?
That's an interesting question. Food fortification has altered what we think of as a balanced diet. Fortification has been helpful in achieving sufficiency of intake for many nutrients, but it can also result in excessive intake in young children. It is amazing that a generation ago, a dinner plate needed to contain green leafy vegetables, fruit, and a protein source to provide a balanced diet. Now, a similar micronutrient profile can be mimicked through a fortified breakfast bar. It's unknown what the long-term consequences of food fortification will be on health, since there is so much more to nutrition than just micronutrients. Another concern is the food labeling system. The daily values on food and supplement labels are used by consumers to make healthier food choices. These values are set predominantly based on adult values. So when using these values to make food or supplement choices for young children, this may result in excessive nutrient intake and untoward effects. This can be especially problematic when it comes to nutritional supplements, which have very concentrated sources of nutrients.
I see. So let's go back a little bit, actually. Are children with autism spectrum disorder very different from the general pediatric population? You mentioned vitamin D and calcium deficiencies being prevalent in ASD participants. Does this parallel the deficiencies for other children or even the adult population?
Yes, it does. While children with autism spectrum disorder are more selective than other children, their nutrition in general does not appear to be any worse than the general pediatric population. In a previous paper, we demonstrated that the gaps in nutrient intake were similar in these two groups of children. Both populations can stand to improve their nutritional intake. In actuality, with our fortified food supply, a restricted diet may not be as nutritionally deficient as it appears, but nutrition gaps still exist. In addition, there are individual children with autism who do have very restricted diets and are nutritionally compromised. So even though in general we're seeing that they're able to meet many of their nutritional needs, some kids certainly have deficiencies. For instance, we recently diagnosed a child with ASD on a highly restricted diet with scurvy here at the university. That is why a dietary history should be part of well child care for all children, especially children with ASD. All children need to eat better for current and future health.
I see. So one of the things your paper showed was that children with autism spectrum disorders are more likely to be given supplements or to be on a gluten-free or casein-free diet. Do you know if this is being driven by physicians or dietitians, or whether parents are taking it on themselves upon themselves to take these actions?
The GFCF diet has been a popular intervention that parents elect to trial to see if it will help their children with ASD. While clinical trials do not provide the necessary support to endorse a trial of the diet, the Autism Speaks Autism Treatment Network data suggests that almost 20% of children with ASD who participated in this large registry are given this diet. Few allopathic physicians recommend removal of gluten in the absence of documented allergy or celiac disease, or removal of milk products in the absence of lactose intolerance or true allergy. However, when families elect a trial of diet therapy, it is incumbent on the clinician, whether it is a physician or dietitian, to counsel the family to provide appropriate supplementation for calcium and vitamin D, as well as any other nutrients that might be compromised. Typically, however, families elect to trial this diet without professional consultation and select dietary supplements without professional advice.
So, sort of, looking forward, it seems that children given multivitamin and mineral supplements still fail to get enough of certain nutrients, and they get too much of others. What can be done by families or physicians to correct these imbalances?
That's an excellent question. Nutritional screening in the context of well child care is important for all children, but especially important for children with ASD who are selective eaters. A good dietary history allows the primary care provider to engage in patient education and parent education and refer children with selective diets to registered dietitians who can recommend targeted supplementation when needed. Families need to be educated to read labels, and labels need to better explain the different needs of children at different ages. There is little regulation of dietary supplements at this point. So it is important that all healthcare providers educate families, because educated consumers will demand appropriately balanced products.
Okay. So we've touched on this a little bit already, but I want to go back to it because it feels like an important point. It seems the GFCF diet can provide adequate levels of certain nutrients, but is still deficient in calcium, for example. From a nutritional standpoint, is the GFCF diet an improvement over an unrestricted diet?
No, I don't think our data supported that. Although children on the GFCF diet do seem to ingest more vitamin E, probably from milk substitute products such as almond milk and soy milk, and also more magnesium. But if the gluten-containing snack foods are substituted out for fruits and vegetables and other nutrient-dense products, it's possible that there may be nutritional benefits. On the other hand, if gluten-containing pretzels are swapped out for non-gluten-containing pretzels that might not be fortified with folic acid or other forticants, there's no nutritional benefit. I think what this data shows is that if families elect a trial of the GFCF diet, there is no likely nutritional harm if they appropriately supplement with calcium and vitamin D.
So what behaviors do children with autism spectrum disorder exhibit that might suggest that their nutritional requirements are not being met without extra attention?
That's a little bit of a tricky question. Behaviors that are known to be associated with nutritional factors include inattention and restless sleep with decreased iron stores. However, few children with ASD consumed inadequate iron in our study. We do not know the implications for long-term deficits in choline and potassium and even vitamin D, for instance, beyond bone health in children with or without ASD. There is literature documenting that adults with ASD may have more hip fractures, and children who are on casein-free diets may have thinner bone cortices. These and other health outcomes, including obesity, need more study. The question of how nutrition affects behavior is a critical one that needs prospective evaluation. A companion study that examined the mealtime behaviors of these children, measured by the BAMBI, which is the Brief Autism Mealtime Behavior Inventory, identified that children with ASD who had more selective diets also had other repetitive behaviors, more sensory symptoms, and more externalizing behavior. Is this the chicken or egg? Do children with more challenging behavior have more selective diets, or is it the other way around? We really don't have the answer to that question yet.
Okay. Well, let's sum up. Tell me why do you think this research is important, and what do practitioners need to pay attention to?
Thanks. Individual children with ASD may be at risk for both insufficient and excessive nutrient intake. Due to their selective eating habits, these children are often given supplements, most often multivitamins. However, because of our highly fortified food supply, multivitamins are usually not necessary. Multivitamins tend to provide more of the nutrients consumed in adequate amounts and not enough of the nutrients consumed in insufficient amounts. In addition, when supplemented, vitamin D and calcium generally are not provided in sufficient amounts to meet recommended levels of intake. Practitioners need to pay close attention to the amounts consumed relative to age-appropriate requirements. Multivitamins rarely provide potassium, an underconsumed nutrient, underscoring the need to eat whole foods. Choline is another nutrient that is underconsumed by most children, and it is typically not provided at recommended levels of intake in multivitamins. In addition, although repetitive consumption of highly fortified foods contributes to nutrient sufficiency, it can also lead to excess intake in young children. Young children have lower absolute nutrient requirements. Therefore, use of supplements on top of repetitive consumption of highly fortified foods can result in excess intake above the upper limit, putting these children at risk for side effects. The daily value on food and supplements may inadvertently encourage excess intake in young children, and the long-term impact of excessive nutrient consumption is unknown. A diet history should be a part of routine well-child care for children with ASD and when selective eating or supplement use is present. Consultation with a registered dietitian can be helpful to identify prudent use of supplements and help the family identify appropriate foods that can be introduced using behavioral strategies when necessary.
Okay, great. Well, that wraps up our interview with Dr. Stewart and Brienne. Thank you both for taking the time. Appreciate it.
Thank you,
Thank you.
Sean.